are the reason for being excited, being a good mom, and liking my job so that when I go home, I can have fun with them. Thank you.
Well, Elsie, that was a great talk. Excellent, excellent exposure about where you went in Milan. I love that story. So we had a good question in the chat from Eric Smith at UCSF about, for those who do the 5+2 pathway, what are the benefits of being board certified in general surgery? Is it useful for applying for jobs, etc.? I'm going to put that, since Niten's first on my screen right now, I'm going to ask him, and then anybody else wants to comment on that.
You're on mute, Niten.
You're muted.
Yeah, that was my answer. Now, I don't think it matters as much as it used to. I think in many places, years ago, you used to be considered a vascular/general surgeon. And now, once you do your vascular fellowship, it's rare, unless you're practicing in, a fairly small area or some area in a multi-specialty group where you're expected to do general surgery. So I don't think that it makes as big of a deal as it used to. But I'm not sure if anybody else has a different opinion on it. But I think when I finished, it was still something that you were still board certified general surgery with the subspecialty kind of a vascular surgery. Now vascular surgery, I hate using the term subspecialty because it's its own specialty. We're vascular surgeons. I do vascular surgery every day. I don't do general surgery. And I think that was a training paradigm that I went through. That was the only one that I had at the time to go through. So I'm not sure how valuable it is in this day and age. And I'm not sure if anybody else on the call has a different opinion on it.
I would wonder that, in rural areas where there may only be one vascular surgeon and it may not be as busy of a vascular practice, maybe that's a situation where, being general surgery board certified may be helpful. Anybody else have comments on that?
Greg, I was just going to kind of echo that. I mean, I 100% agree with Niten. Like, I was all proud that I had my double board certified, but do I use general surgery in my everyday practice? Absolutely not. And if I, do an aortoduodenal fistula, am I going to call the general surgeons to repair the bowel? 100%, because that's what I'd want for my family member, because I don't do general surgery anymore. That being said, if you know the type of practice and where you're going to end up practicing, if you are in a rural place, there still is a pretty high demand for that multi-specialty group where you might be a vascular surgeon, but you do a lot of access and some endo stuff, but you also take general surgery call. And so, I think if you know kind of what you're going to go practice in, that board certification may come in handy, albeit that's probably a rare entity. But, everyone knows kind of in general, maybe where you want to end up practicing. And if you're from a very rural town, you want to go back there, it could be something that could be useful for you.
Yeah, just bear in mind that it used to be that having general surgery boards was a precursor to vascular surgery certification. That's no longer present. The vascular certificate is a primary certificate. You can complete general surgery in 5, 6, 7 years. You don't have to get board certified. You can just go right on to get board certified in vascular surgery. And the same on the 0-5 pathway, obviously, that would be the main thing. But American Board of Surgery has moved it to where it's a primary certificate and there's no need for general surgery board certification at all. The comments that were just made are very valid, depending on if you want to take general surgery call or just somehow be involved in it. But I think for most people, that certified in general surgery, a lot of them are letting that certification lapse and just staying primarily certified in vascular surgery.
I'll just add that I think the one caveat I'd give you if you're thinking about joining a multi-specialty group where, it's 5 general surgeons and 1 vascular surgeon. My friends that have been parts of those groups say that they take general surgery call, but generally when there's a vascular issue, they get called for it. And so just be cautious in the practice you want to pursue as you move forward, because those things can happen.
We got a guest speaker here, Dr. Ziegler, who said if you're going to be involved in a trauma-heavy practice, general surgery training may be useful. yeah, you could go the Dr. Magee route and get general surgery, trauma surgery, and vascular trained. I don't think there's anything wrong with being trained, you know, having more training. I think that can always be useful depending on what kind of practice you're in.
While we're waiting for a question, you know, Elsie, you're the only one who's gone through the so-called 0.5, although yours is like a 0.7. But you know, I think many of us, I didn't have a choice. Vincent didn't have a choice. Leanne, I don't know if they 0.5s were around, and Sarah, I think it was just nation when you were starting. The question I always have to everyone is that if you knew now what you knew then, would you pursue a 0.5 program? Elsie, you're excused from this one because you already did it. But Sarah? You're muted. We'll come back to you, Sarah. All right. I'll go to Leanne.
Oh man. You know, it's a loaded question. Hindsight's 2020. I mean, I had no clue. I think that the medical students have more information available to them now than they did when I was a medical student. Like joining a VSIG and, you know, getting involved early on. I didn't have that exposure. So if I had been forced to make a decision straight out of medical school, I would have gone into something different and not been as happy as I am today. So I can't say that I'd go back and do things differently because I love the path that I took. That being said, I do think it's really valuable, and I think Elsie did a great job of giving an awesome presentation that, you know, really as medical students use the tools and the, you know, things available to you and really explore all of your options of things that you're interested in, because now you have that. You have, you know, conferences and VSIG meetings and interest groups and things that you can join to kind of get that sense. Because I do think that, you know, there is something to be said for the 0 and 5 in terms of getting out and starting your life a couple years earlier than we did. And so I think there's values in both pathways, and it's nice that they're still available, you know, depending on what kind of environment you're, you know, starting out in as a med student and what you're exposed to.
Can you guys hear me now?
Yes.
Oh, sorry, I don't know what's going on. I echo what Leanne said. I think for me, I had no vascular exposure at all in medical school. So had I had to decide then, I would certainly not be here today. I love my general surgery training. I think it totally changed where I am. I came in with very little research and no vascular exposure. And where I am now is fairly heavy research. And obviously I'm a vascular surgeon. So I would definitely have taken the same pathway, but that worked for me. And I think that's the beauty of having both options is whatever kind of your pathway is as a medical student, you can still come out of this in terms of whatever field you want.
Do I get to answer, Niten?
Vince, you're next.
I would do the 0.5. If I knew, if vascular stayed like how it was when I finished, I think general surgery helped because of all the open cases. But then general surgery moved to laparoscopic, vascular moved to endo. And so if I had all that information now and applied, I'd absolutely do the 0.5 and not do general surgery. What am I doing laparoscopic surgery for 5 years to prepare for what? So I guess, you know, from my point of view, that's what I would do exactly right now. I just have to get in because these young kids are smart.
How about you, Greg?
Yeah, you know, Leanne alluded to the fact that I've done a lot of training, and I would agree with what she said, which is that I really value the training I had. I don't think I would necessarily do it differently because that's sort of like she's saying, you're not happy with your life now. I'm actually very happy with it. But knowing what I know now, and if I was going to start now, as Vince said, if you know you want to do vascular, I recommend people do the 0.5. I think it's very clear that pathway is, you know, superior in the sense that you get immediately into what you want to do for your life. If you don't know for sure, you just know you want to be a surgeon, you're considering multiple different pathways, then that's where I think the 5+2 pathway is better.
Elsie, would you still do it? Same thing?
Yeah, it's funny because the OWN 5, I think it was the third year it was in place when I chose to do it. And it was actually a hard decision because there was the thought that, oh, you're not going to be as good a surgeon because you didn't get all the general surgery training. But at the same time, around the time I was applying, the vascular surgeons here were starting to think of letting their general surgery lapse. And I was like, oh, that's interesting. If they're no longer caring about being board certified in general surgery, then maybe I'll do this OWN 5 thing. The other thing is that like I have a hard time doing things that I'm really not excited about. So when I was applying, like, they say, oh, it was so early that they said apply for OWN 5 and general surgery. And so like I focused on my OWN 5 applications, wrapped that up with a bow. And then I looked at my like general surgery application. I started writing the essay and I was like, no one's going to believe I want to be a general surgeon. So I'm just going to go with these 8 and hopefully I get in somewhere. So yeah, that's it, but it was not necessarily like, like things when they start up, right? You're not sure that they're going to be successful. And so back then it was hard to know like for sure and be 100% confident that choosing this path was going to work out.
It's all wise words, and I think we all treasure our training. I look back at my training and I loved it. I mean, it's hard being and for the medical students, it's kind of weird. You're probably thinking about residency, being real, just a time suck, and it is. And there's times in residency that you hate the day because it's just so hard. But when you look back on things that were hard, I think you always look back with fond memories because it was hard and you got through it. And I think we all treasure the time we had. But I tend to agree with Vince. I think I would do a 0.5 now because I know that I want to do vascular. If I know now that I wanted to do it, I think I would pursue that pathway. There is a question from the chat. It says, do you feel that integrated vascular applicants are viewed holistically, or is there still more of a traditional focus on step 1? And is that changing as we move to pass-fail applicants?
I can answer some of that. I think we're all at programs that have an OWN 5 component as well as a fellowship. But in terms of the last few batches, like the step 1 has been like a good marker. I think it has been de-emphasized in more recent years and more recent cycles. In terms of holistically, like you can match well in integrated vascular if you've got other things that are really amazing too. Like if you're really into research and you show like great productivity, or you're really into teaching and you've demonstrated like a track record for it, a bad step 1 score won't pull you out of the game. So I think there is some holistic evaluation, although we have looked at step 1 scores just as okay, this person seems like a someone who challenges themselves.
I think you're right, Elsie, that I mean, at UW, I mean, we do the same thing. And Sarah's one of our assistant program directors, and we have everyone review all the applicants. One thing about the integrated pathways, there's usually about 150 applicants to go through, not a few thousand. And so there's not stringent cutoffs that you have to have. And I think you can look at things that are important. There's a lot of changes that are happening. This was a big discussion, and Vince was there at the APDBS where they're talking about not having a step 1. And what's going to happen now? Is it all going to be on step 2? Who knows what's going to happen with that? But I think a lot of emphasis will rely on the letters of recommendation that you get, the rotations you do, the interest that you show in vascular surgery. So I do think that there is probably a bit of more holistic kind of review of an integrated pathway, because you're not reviewing 800 or 900. It's usually about 150. But there are some metrics that I think you have to be able to do. You have to be able to pass your boards to be a vascular surgeon. So no matter what, those things will come into play. And it's not that we all want people to succeed, but you still have to be able to take the tests and pass them. I'm not sure if anybody else has any other comments on that.
I think we have like 5 minutes left, and we have a really cool question that I think would be awesome for everybody to kind of weigh in on and end with. which is what are the coolest things that you see happening in the next 5 to 10 years in vascular surgery, and what advances, techniques, devices, etc., are you most excited about? So I don't, Sarah, you want to start?
Sure. I mentioned that much of my practice is complex aortic, and I think for me, that is the game changer. Right now, we can only take care of patients with thoracoabdominal aneurysms on label, so to say, at a couple of sites around the country because the devices are not widely available. And what does that mean? It means most patients with large aneurysms, they're elderly and they're not otherwise healthy. And so if it weren't for these devices, they would not have an option for repair. And so I think the fact that, you know, in the next decade, these devices will be more widely available is super exciting because it allows us to treat so many more patients moving forward. So I think that I think is what's really exciting, at least to me. That's also my area of interest, but I think it's super exciting.
I'm going to go against the grain and say I'm like so excited about the technology that's coming up, and you know, and I think it's going to be in the next 5 to 10 years about how we get blood flow to a foot with no pathway to the foot. And so, you know, you have these patients who are end stage diabetics on dialysis who have the no option foot, and there's so much exciting stuff in the forefront of with deep venous arterialization and below the knee technology in terms of drug-eluting stents and shockwave and serenator, and there's just all this stuff being developed to help these end-stage patients to attempt limb salvage. And so I think there's going to be, it's all very novel right now, but I think there's going to be a lot in the forefront because there's a ton of really, really smart people that are dedicated to working on this. So I think for me, that's most exciting.
Elsie?
Sorry, I need to mute. I will say that I think what's going to be exciting is the endo in the non-X-ray suite, like, or minimum X-ray suite. Like I had the chance to tour the Philips facility in Amsterdam, and they're one of a few companies that are working on like fiber optic light so that you can guide wires and devices without stepping on the X-ray pedal for long periods of time. So just from like a environmental safety, longevity in a vascular career, patient safety standpoint, I think that'll be really cool.
Vince or Greg?
Yeah, I think, you know, Elsie's point I agree with entirely. The, you know, basically the ability to do procedures endovascular without significant radiation. And I think probably in the near future, robots are going to come back. You know, the ability to basically guide catheter wires, sheets while sitting at your desk.
And for me, I think that we've been great as a society and as a specialty identifying areas that we can improve our care. And the term disparities has come up in a lot of our papers. I think there's a lot of very interested and motivated people to eliminate these in any areas in vascular surgery and in surgery in general. So I think over the next 5 years, that's going to probably take place.
Yeah, I don't know if there's anything cooler after all the stuff you guys said. So I think that was fantastic. Well, listen, our hour is winding up. We got about a minute left. I just want to remind folks that we have a DI webinar Thursday at 5 p.m. And that's being led by Dr. Chavez and Dr. Rowe. Also, I want to remind the attendees to apply for the VSIG scholarship to the Western Vascular. It's in Victoria, Canada. So the one thing about Western, you saw some of those pictures that Leanne had and Sarah had. They're pretty cool places. That's a great thing about living on the West Coast, is that the Western Vascular is always at a pretty cool place. So I would highly recommend that you apply for that. And the meeting will be in September. And you know, I think everyone is looking forward to it. And please go to the website and apply. If there's anything else, I think we're about done, guys. We're at 6 o'clock. I'd like to thank all the panelists. That was a great session. And, you know, and once again, if there's any other questions, please feel free to reach out to us. We can, you know, we're all available to talk about the specialty. You could hear how much everyone loves what they do, and we would all be happy to talk to you more about the specialty. But thank you guys very much for attending, and I'd like to thank all of our panelists for participating, and look forward to seeing you guys soon.